So I thank Dr. Sahil for including me in this course, and I'll just be briefly covering aging of the face and some of the basic anatomy along with the danger zones based on certain procedures. So the basic features of aging that we commonly address are volume loss, fat loss, superficial lines and wrinkles, and the most important thing is that we need to keep in mind is there is also some amount of bony resorption which takes place, as well as overall descent of the face. So with respect to bony resorption, in the lower face you can see how the angle of the mandible increases along with the age, and in the orbital region you have bony resorption mainly in the superonasal region and the inferotemporal region. So the area which is sort of the where the fat lies, where you can see in the younger individual, it is sort of well kept within the orbit, and in the older person it starts becoming prominent. And also where in the older person the lid cheek junction also sort of starts getting eroded because of the bony resorption. Now the other thing we address usually is the aging around the mouth. So here you can see the elasticity of the skin gets lost much sooner than what the orbicularis ages. So the orbicularis action becomes a little more prominent than what the skin can take. And the other thing here you need to note is the temporal hollowing. So with age you see this temporal hollowing along with the other changes that I mentioned earlier. So in a 30-year-old individual or somebody between 30 to 40, you generally start seeing the wrinkles forming. So not just the static dynamic wrinkles that happen with facial expression, it's also the static wrinkles which start appearing with the age. In older individuals, you will see that the brow starts to descend. You can see that the tear trough elongates, and they start developing perioral lines. And somebody in their 50s, they tend to have again a deeper tear trough, and along with this the nasolabial folds start becoming more prominent. So these are things that we keep addressing one by one. And somebody above 60, you can see the prominent jowls that start to develop because of the overall facial descent, and all the changes that we mentioned till now, they become more and more exaggerated. Now when we assess the face, we look at the facial shape with respect to the cheek and the chin, the length of the forehead, the brow shape and the height, the lid height, and the nose and lips is something that we don't commonly address at our level, and the skin texture and the clarity. Now you need to keep note of where all the fat compartments are. So this first diagram shows all the superficial fat compartments, and the second diagram is all the deep fat compartments. So these are the areas which we generally target when we want to do volume augmentation. And with respect to the muscles of the face, what we most commonly address is of course the procerus and the corrugator for the frown lines or the 11s, the frontalis muscle for the horizontal frown lines, and of course the orbicularis oculi. Along with this, when you need to look at the lower face, for example the masseter injections, you need to be careful of this risorius muscle. Okay, so this can change the shape of the smile if at all the injection tends to migrate to other regions. So once we talk about the muscle, we would immediately talk about the wrinkles. Like I mentioned, the wrinkles which are along with expression, and then along with which are static and always present. So it keeps increasing with age, of course. So as you inject botulinum toxin in patients who are older, they would need several more sittings for the aging or for the static wrinkles to appear less. Now these are the most common areas that we address. So like I mentioned, the glabular lines, the frontal lines, this superior sulcus hollowing, of course, the tear trough, the crow's feet, the infraorbital hollow, this malar projection, the nasolabial fold, and at times the smoker's lines. Now when it comes to the safety of these injections, it's important to know the anatomy of the vessels that come across in this region. So not only do you need to know which vessels are where you inject, you need to know where you can inject superficially, where you need to inject deep, that is for the fillers, and where the anastomoses are, because these are the areas which are most commonly associated with embolic choking. So like I mentioned, so you can see here, these are the internal carotid artery vessels, and these are the external carotid ones. So in between the areas where you can get these embolization, because these are the areas where these two arteries meet. And this again, this diagram I will be discussing later. Now, why the lymphatic system is important now is because as people age and they get more and more filler injections done, so they develop layering of fillers. And if a patient goes to one person and gets fillers, and then goes to the next person and gets more fillers, without leaving adequate amount of time between both the filler injections, they tend to develop lymphatic stasis, which causes long-term swelling. And this doesn't respond generally to even hyaluronic acid injections. So it's important nowadays to make sure, if a patient already has fillers in their face, to get an imaging done or an MRI done, and that will help you locate the location of those fillers, so that you don't go and inject more where it's not required. And it's important again to keep a note of the male female characteristics, and the where you need to do what augmentation. So the eyebrow shape and the projection of the forehead, these things are much different compared to the female in a male. So you don't want to cause a large arch of the eyebrow, and you address these things based on the characteristics. Now, these are the areas which are again prone to these embolic phenomena, because of these arteries converging. So in this glabellar region, we try as far as possible not to go in with fillers. And whenever people are injecting fillers in the nasal bridge and nasal tip, they have to be very careful not to cause necrosis. So injections which are within 1.5 centimeters of the superior orbital rim, you would have superficial injections, because the vessels lie deep in this area. And above that, you would have deeper injections to avoid the vasculature issues and reduce pain. Now, along the temple, you have the superficial temporal artery. So that is one danger zone, and you need to palpate that and be careful where you inject. And here the infraorbital foramen lies here. So you can again have issues with embolization here. So you inject with a cannula ideally. However, if you are injecting deep and just over the periosteum, you can even inject with a syringe, with a needle. Now again, along the lateral zygomatic arch, you need to keep it along the bone, but this is a low risk area. So you don't have to be too worried about this. You can inject deep in this area as well. And the other danger area is the nasolabial groove. So again, you can use a cannula in this area, because cannula is blunt and would prevent an injection intravascularly. Now, Allergan has given this outline of where you should inject, but again, you'll have to customize it based on where the patient needs treatment. So you can use these codes to make sure that you document where you're planning to inject. And this shows the danger area. So this CK3 is a danger area, again, where I mentioned the infraorbital vessels are. And this is an area where you have to be very careful. So you can either put in a cannula here and turn the cannula towards where you want to inject, or you can inject directly over the periosteum for the tear trough. Now, why are we being so careful about these injections is because you can have an anterograde embolization. So that would be towards the superficial vessels, which can cause a reduced perfusion, blanching and severe pain, in which case you stop injecting and massage the area and make sure that they don't develop necrosis. And the other thing is, of course, a retrograde embolization. So towards the central retinal artery. So you would have visual loss if this took place. So in these conditions, there is a controversial talk about retrobulbar hyaluronidase injections, but what actually works is the superficial injection. So for example, this is a patient who had issues in the mandibular injection of filler, and under an ultrasound guidance, they were able to re-establish flow within about an hour or so, because once you inject the hyaluronidase, because it's a hyaluronic acid injection, you can re-establish flow. So that was just a rough outline on basic anatomy and danger zones, and I'll just hand it over to Dr. Adit.
Thank you so much, Dr. Ritija, for that talk. So, any of you are practicing aesthetic in your private practice on your institute? No one. Functional Botox. Functional Botox there, right? So you inject only for blepharospasms, hemifacial spasms, or for other indications as well, for bruxism, for strabismus. This talk would take us through the in and outs of Botox for cosmetic purposes.
Good evening, everyone. So, in this talk, what I'm going to do is I'm going to brush through the very basics of botulinum toxin injections from the perspective of a beginner ophthalmologist and take you through all the various guidelines that have been formulated for injecting this. Now, we all know that there are cosmetic indications of Botox, and as ophthalmologists, we have been using Botox since times immemorial for functional indications as well, mainly blepharospasm, hemifacial spasm, and recently for migraine, strabismus, and even epiphora. Now, whenever we think about this course, is going to focus on more of the cosmetic part. Whenever we focus on injecting Botox, first and foremost, rather than injecting is very easy. But to understand the cosmetic patient or to evaluate our expectations or the goals and expectations of a patient is very important. It is very important to screen out the patient. So if there are any red flags, you should avoid injecting Botox as a first go. And the third thing is that you should always look at the patient holistically, as Rituja has already showed that anatomy is in layers. So you should look at all the layers because Botox cannot treat all the layers. It can treat only dynamic lines, and that is what has to be conveyed to the patient as well. Now, a lot of ophthalmologists, when they talk to me, they tell that I try to convince the patient for Botox, but they usually don't get convinced. But the dermatologist is very easily able to convince them. Now, whenever you're dealing with these patients, it's very similar to LASIK patients or multifocal IOL patients, where you have to be very subtle with your words. You have to avoid using harsh words. You have to sort of tone the words down and try to convince them properly. Now, before injecting the Botox, you need to also evaluate the patient. Now, what I do is basically evaluate the patient photographically as well as videographically, because what you are going to target is the dynamic lines. So, you should always ask the patient to frown, perform extreme ranges of movement so that you can actually delineate which muscle to be targeted, because every patient is going to be different. It's not going to be the same injection patterns for every patient. A particular patient might have more eyebrow problems as compared to the crow's feet, or more forehead problems as compared to the other area. After this, to make the patient comfortable, because you want the patient come back to you again and again, you should always apply a numbing cream. So this is nothing but a mixture of prilocaine and lidocaine. You apply it on the skin, keep it at least for 30 to 45 minutes. It penetrates the skin and numbs the dermis and epidermis, so it causes numbness of the prick. The injection is a little painful, but the prick pain can be avoided by applying this EMLA mixture. Once this is done, you can even apply a adhesive barrier. This barrier tape helps in perfusion faster. So if you are in a hurry or the patient is in a hurry, then you can use this occluder film which comes with the numbing cream, and then keep the patient with the occlusion cream. After this, you have to always mark the points. So to mark the points, you need to know the location of the muscles. Now, if you know, we'll focus on the periocular region. The major muscle is the orbicularis oculi, which mainly is targeted for the crow's feet and the eyebrows, and then the eyebrow depressor muscles in the center, the procerus, the corrugator, and sometimes the depressor supercilii. And in the frontal region, the frontalis muscle. So once you know the anatomy of these muscles, where they origin, where they insert, and how strong they are, you can titrate the dosage of your injections. Now there are multiple toxins available in the market, especially since the patent of botulinum toxin, which was owned by Allergan, has expired. There's a slew of companies which has come, like Nabota, which is a Korean company marketed by Dr. Reddy's lab. We have Dysport, Xeomin, and a lot of Indian companies like CX and Stanox now, which are cheaper than the original variant. The effect is variable, but is suitable for patients who are on a tight string budget. Now there are consensus guidelines, if you go and look into literature, which have been given by the in the PRS journal in 2004, and recently even in Indian consensus guidelines have come. where they exactly tell you how to dilute the injection, how to store it, how to achieve the normal concentration that you want, and how to handle the injection. Usually, once you reconstitute Botox, it should be used, the label says that it should be used in the same sitting within 24 hours. But we have achieved success by even keeping it in the refrigerator for even 1 month with a little bit of reduced efficacy, but it still works. One thing which you should always have is a patient chart. So if you have a patient chart, if the patient comes back to you again and again, this helps because you know exactly how much units you have injected in which muscle. And if the patient is happy with that pattern, you continue the same pattern. If the patient says that this pattern did not work very well, you can modify this pattern and sort of suit it according to the patient's liking. Although Botox is a cosmetic procedure, consent taking is very important. You can find these consents online. You can find them, even AIOS has a consent for Botox now. So consent taking is very important because these patients have very high expectations. So you should always be safe medico-legally. Now coming to different indications around the periocular area, the easiest to start off is the crow's feet. So for an ophthalmologist, crow's feet can never go wrong. Now, when you think about the crow's feet, basically it is nothing but the orbicularis, which is a sphincter muscle which runs all around the orbital rim. When you squeeze the orbicularis or you try to scrunch your eyes, you will see that crow's feet radiate along the lateral border of the eye. And they can be variable, they have different anatomies, but to start off, there are 3 points which you can choose. The superior, the middle, and the inferior, which you can see very clearly at the right ITDs. And usually a dose of around starting dose of around 12 to 30 units suffices, 12 in women and 30 in men, because men have more bulkier orbicularis, and 2 to 5 points can be selected. Now this is a video which shows injection, how it can be done basically in patients for crow's feet as well as eyebrow. As I told, this is the orbicularis muscle. So while injecting the crow's feet, as a beginner you should mark those 3 points. After that, using a 30 gauge needle, because the pain prick sensation is less, you inject in the crow's feet. Ask the patient to animate so that you know exactly where you are injecting before. As a beginner, I would recommend to keep the needle direction away from the globe, because you would avoid diffusion of the toxin into the lateral orbit and sometimes cause diplopia. Or you can keep a thumb or a finger within the orbital rim so that you know the position of your injection. Once the crow's feet are targeted, then you can shift your attention towards the eyebrow. So in this patient, we have done 4 injections, but you can extend even more depending on what effect the patient wants. Following this, in the same sitting, because usually you would not inject crow's feet in isolation because it also changes the eyebrow position. Now this is the corrugator muscle which is being injected. Now if you observe closely, my thumb is below the orbital rim. This is to prevent or to exactly pinpoint the location where the toxin is going, so that it doesn't diffuse downwards into the levator superioris and cause ptosis. So this is the tail of the corrugator which is being targeted. Around 2 to 3 units here and around 3 to 4 units in the main belly of the corrugator are targeted. And then you shift to the lateral eyebrow. Now the red muscle is the procerus. This is depressor supercilii, which is lower, and this is the corrugator. Now when you go to the lateral part of the eyebrow, this is basically more commonly used for women who want an arched eyebrow. So this is right in within the, sometimes you have to go within the hair of the eyebrow as well, because they want a lateral arch. So 1 to 2 units at 3 points to lift the tail of the eyebrow works very well. At this point, sometimes you also have to inject in the frontalis muscle to prevent spock formation. Now similarly, I am doing the crow's feet on the other side. So this is basically the injection pattern followed around the periocular region. But you should also know that not all crow's feet can be treated with Botox. Sometimes because of aging, there are wrinkles and changes around the eyes which cannot be treated with Botox. These are static wrinkles and need surgery or filler injections to treat them. Now coming to the forehead, this is also a very common area which can be injected without any risk, because it's a very avascular area and there's just the skin, muscle and the bone. Now, you need to know the anatomy of the frontalis. It can be different in different people. Some people have a contiguous frontalis, some people have a bifid frontalis. The rule is that you should stay 1 centimeter above the eyebrow so that you don't end up injecting the orbicularis and paradoxically depressing the eyebrows. Avoid quizzical eyebrows or the Spock phenomena by treating the lateral part of the frontalis as well, and do not inject too much in the frontalis muscle because you don't want a frozen appearance. So now if you see in this gentleman, the frontalis muscle is contiguous. You see it's continuing from the right to the left, and this is after injection. So you customize your injection pattern according to that. The red line is just a line where I usually don't go below because I don't want the eyebrows to get depressed. Sometimes you have to combine it with a filler injection, and sometimes in women you have to underdose it because they don't like a frozen appearance. Now, consensus guidelines for treating forehead lines, usually in women we start with a dose of 10 to 15 units. In men, a dose of 20 to 30 units is sufficient. Now, people sometimes don't want complete frozen effect, so there is something called as micro droplet Botox or watercolor Botox, where you dilute the Botox further and just put very micro aliquots all along the forehead so that the frozen look is avoided. Eyebrow we have already spoken about. These are the usual points which we have shown in the video. For the corrugator, the depressor supercilii and the lateral orbicularis. And the units which are usually followed are around 4 units each in the corrugator procerus and 2 to 3 units in the tail of the corrugator, which helps in getting a good lift. Now, for the eyebrow in women, we usually begin with a dose of 20 to 30 units. In men, usually 10% more, so around 30 to 40 units. Sometimes you need to combine botulinum toxin injections along with fillers. Now, if you see in this lady, even after doing Botox, these lines are still left. So these lines are nothing but static lines because of constant dermal adhesion of the muscle, which stay even after Botox injections, and these need to be dealt with fillers. These are advanced filler indications which should not be tried by beginners. Now, sometimes we also use Botox to augment surgical results. Now, this lady underwent a blepharoplasty. After a blepharoplasty, you see she also needed a brow lift, but sometimes women don't want to undergo a brow lift because it's an extensive surgery. So you can just do a little bit of Botox for the eyebrows to elevate and get a better result, especially in the immediate post-op period when you want to make the patient happy. Ptosis as well as tarsal platform show also can be adjusted by doing Botox in the periocular region as seen in this lady. And last but not the least, we all know that Botox causes ptosis, but it can also be used to treat mild ptosis. If you see in this gentleman, if you inject Botox very close to the lash line, what it does is it causes paralysis of the pretarsal part of the orbicularis so that the LPS can act unopposed and can cause elevation of the eyelid to a tune of 1 millimeter. Last but not the least, you should always call your patients for follow-up at 2 weeks, especially if you're injecting them for the first time, because sometimes you might end up with something like this where because of unopposed action of one of the muscles, you might get a quizzical look or a Spock phenomena, which can be very easily adjusted by just putting 1 unit in the superior part of the eyebrow and get a good result. Eventually, the aim of Botox injections is not to have the same expression for each expression. You should customize it so that the patient can maintain their original expression, but at the same time get good results and good outcomes from the injections. Thank you.
Thank you so much, Dr. Adit. Can we have the next speaker's talk, Dr. Pallavi's talk, which is a pre-recorded one? Dr. Adit, what do you see as far as a beginner is concerned? What we learn is that it's always better to give the minimal amount of units to begin with, and then step up gradually. Call the patient back after 2 weeks and gradually see what suits the patient and what not. What is your say on that?
Correct. So when you're beginning injections, you should always begin with the least possible dose. And then you can always add it on, because you can add on, but you cannot reverse it. Once you do Botox, for 3 months, the patient is going to stay with that result. So it's always better to start slow and then usually call them on 2 weeks so that you can adjust, add on more dose, or even titrate it according to your or the patient's needs. So always better to be starting slow.
Yes, so this must be for the new patients that come to your OPD. For those patients you have already charted out.
Once you have a chart, then you can just go and follow the chart if the patient likes, or if the patient doesn't like, then you have to modify the chart.
So the charting becomes very important in all these scenarios.
The first charting is very important.
And for the filler that you inject in the glabella region, do you prefer something like a Volbella or a Volift?
So it's very variable. I don't actually prefer any filler. If I have some filler, I use it, except Voluma, which is thicker or denser. So I have done Volbella in the glabella, but I try to be as subdermal as possible. I don't go very deep, because if you inject deep here, there are vessels which can cause, this is the danger area of the periocular region. You can cause potential blindness if the filler goes in the vessel there.
Dr. Adit, can we play the next video? Her talk on hyaluronic acid fillers, technique, tips and tricks.
With the SSTC course course, we have for Botox injections
Can we
tomorrow.
have the volume?
So let's just get right into it. We're going to talk about hyaluronic acid gel filler, some techniques, tips, and tricks which can help you getting started with this procedure. So what we're going to cover in this talk is we're going to talk about orbitofacial aging, how it happens. We're going to talk about some general principles when it comes to filler injections. And I'm going to talk about 3 specific areas that I really like injecting, and I think that really give you the biggest bang for your buck. All right. So, whenever we talk about orbitofacial aging, we tend to have more of a 2D concept, or even when patients come to us, everyone's basically talking about how they have excess skin in their eyelids, or uh, how the skin is sagging in the neck. But what we need to understand that the aging that occurs is not 2-dimensional, it's 3-dimensional. So there's a lot of fat pads all over the face which give it the youthful look. And essentially, a lot of aging that happens is because of the deflation and descent of these fat pads. So when, we have to change the way we think about these concepts. Earlier, what we used to talk about excessive laxity of the upper eyelid skin, it's not as much laxity of the upper eyelid skin as it is the deflation of the eyebrow fat pad. Similarly, there is deflation and descent of your mid-face fat pads. And essentially with age and gravity, what the skin is trying to do, it is trying to combat the activity of the muscles. So once we look at it differently, I think we will be able to treat these aging changes differently as well. So some general principles that I really like to keep in mind for filler placement. And as it is with any aesthetic treatment, it goes through waves of different types of trends and fads that happen. And now, we're in the age of undetectable aesthetic procedures, which has always been my own natural, preferred aesthetic. Because the idea is that you want to enhance the features that are already present in the patient, that's coming to you. So less is more. You want to make subtle changes which take care of these aging changes that have happened and not do anything drastic. And so when you want to apply this principle of less is more, it's very important to understand how lights and shadows come into play. So if you look at the face and if you look at how the light is projected on the face, there are certain areas that tend to project more as shadows. So if you have the tear trough, because you have the eye, so there is the shadow of the eye. So this tends to look darker, or the temporal hollow. So once we start looking at these things more carefully, we'll understand that addressing just these areas where the light tends to form a shadow will give us the best result when we look at injectable treatments. So now coming to area-specific filler injection techniques, I'm going to talk about 3 specific areas that I really like injecting. The first one is the brow fat pad. So if you look at the anatomy of the brow fat pad, we're all ophthalmologists here. We know that you have the roof superiorly and you have the SOOF inferiorly. So the roof is the retroorbicularis oculi fat pad, and this is what gives our eyebrow the nice, full look, which is so typical of a youthful eyebrow. So when we look at it, sometimes we tend to confuse this fullness, with the eyebrow hairs. We tend to confuse the eyebrow hairs with the eyebrow, which is not the case. As decades change, the way you style your eyebrows change. So in the early 2000s, it was very fashionable to have thin eyebrows. Now it's fashionable to have thicker eyebrows. Some women also get eyebrows tattooed. So you have to understand that when you look at restoring the eyebrow fat pad, you're looking at the fat. You're not looking at the hairs or the position of the eyebrow as such. So it's important to look at that. And what happens with age is that there is deflation of this fat pad and there is descent, which leads to, what is one of the common aging changes in this area. So a lot of these patients will come to you with the complaints of saying that I have excessive skin. Now you need to understand that yes, excessive skin might happen because of the deflation, but the majority of the main factor which is playing a role in aging in this area is the deflation of this fat pad that you have here. And in a sense, once you understand that it's the deflation which is causing the aging, you would want to re-inflate this fat pad rather than taking a lot of excessive skin away. So now where to inject? I think in this area, you have to understand that you want to kind of reinflate this fat pad that you have here. I like to go laterally. I don't like to inject very medially in these cases because you have the neurovascular bundle and that's a high risk area for occlusion. But in the lateral area, you're pretty safe. So you just want to bunch it up and kind of go in laterally and re-inflate the brow fat pad, which gives you like a really good result. You can take care of the superior sulcus hollows and really restores a good sort of voluminous look in that area, which restores the youthful look. The second area that I'm going to talk about, very common, um, most of the ophthalmologists sort of want to do the tear trough filler. So let's talk about the anatomy. What are the changes that we see in this area? Now, when you look at the tear trough anatomy, there's a couple of structures that are important. You need to look at the orbital retaining ligament, which I would say is the most important area, which kind of forms the barrier between the orbital fat prolapse, which is superior to it, and you have the malar fat pad, which is below it. And essentially, what happens is that there's thinning of the tissue above the orbital retaining ligament, which causes a trough in this area, which looks very obvious and is what most patients come for. So when you look at the tear trough, it is this orbital retaining ligament, which is present inferiorly, but it kind of extends all over the eye, and you have that hollowing all over, 360 in the face as the face ages, but we do notice it more inferiorly. And in this area also, you need to understand that there's two troughs. One is the septal confluence hollow, which is superior, which is just below the orbicularis, and then you have the zygomatic hollow, which is below the orbital fat prolapse. So when we're trying to fill the tear trough, we're trying to fill the zygomatic hollow, which is inferior to the orbital fat prolapse, which is just over the orbital retaining ligament. Now, where to inject? Again, there's a lot of conversation about whether you want to use a needle or whether you want to use a cannula. Regardless of whatever method you're using to inject, I think what is important to understand that you want to be injecting in the preseptal space, because once you cross the septum, you're injecting this product into the orbit, and that you're wasting product like that. So you want to be injecting in the preseptal space. So in order to sort of fill up that trough that is there, and how I like to do is I usually like to use the needle for this, and I like to go all over the orbital retaining ligament, starting from the medial to the lateral area, injecting in small aliquots, so you can see that inflation happening right as you do it. And always underfill rather than overfill is what I would say, because less is more in this area. You can always do more if you want later, but doing a lot and then dissolving it is just something that we should not be doing. And tear trough filler, the good thing about it is that it lasts for about anywhere between 18 months to 2 years. Great results, and excellent option for people with hollowing in this area, especially younger people who have good skin quality. And the last area I'm going to talk about is the temporal fossa. Again, something I think which we ignore when we look at aging changes of the upper face. But I think it's a great area. It really gives you a great result if you learn to identify and inject it properly. So understanding where the temporal fossa is, obviously it lies over the temporal bone, and going from the skin to the bone, you have the skin, the subcutaneous tissue, you have the deep temporalis fascia, the temporalis muscle, and you have the bone. So what happens with age is that there is resorption of the bone in this area, and there's also deflation of the subcutaneous fat, which leads to this hollowing that happens with age. That becomes very prominent. If you look at this woman, she's got these hollows, which is something that you might not look at one go, but it overall, when you're assessing the face in general, it makes a huge difference. So where do we want to be injecting in these patients? You want to ideally be above the deep temporalis fascia, but when you are injecting, it's difficult to determine, when you're crossing the subcutaneous layer, when you've crossed the deep temporalis fascia. And one of the thing one of the things to be careful about is that you have the neurovascular bundle behind it. So you don't want to be injecting into that. So one of the easier ways of injecting in this region is going straight down to the bone. Once you're going straight down to the bone, you know that you're not hitting any neurovascular bundle, and then you just kind of, fill up over there, and you can feel the whole layer lifting up, and it has great results. If you look at the before and after, it's a very subtle change. It's not something that's going to be very obvious to the eye, but that's what we want. It overall gives a fairly youthful look, and quite popular. So to summarize, a lot of the upper and mid face aging, it relates to the loss of your subcutaneous and deep fat pads. There is deflation of these fat pads, there's atrophy of this fat, And it's important to understand how lights and shadows play a role and in enhancing your looks, and also in terms of enhancing what aging changes there might be there. Replacing volume is a very powerful tool for facial rejuvenation, and I hope this was helpful. I'm hoping to see a lot of you at the course for Botox tomorrow, and thank you so much for your time and attention.
Now, I call upon Sahil Agarwal to speak on surgical eyelid rejuvenation for optical aesthetic outcomes. I think this is the talk which actually, as surgeons, excites us all.
Yeah. So, slides move नहीं कर रहे. I'm unable to move the slides. Yeah. So that's my mother, who has gracefully aged from her 1980s to till date, having all of them: the hooding, the tear trough, periorbital holding, fat herniation, the mala fat pads, and the prominence of nasolabial fold and jewels. But yet, I have not been able to convince her very well for undergoing any of the rejuvenation procedures. So, selecting the right patient who is very motivated is very important. Blepharoplasty is the most common facial aesthetic surgery worldwide. It could be mostly done in cases with cosmetic indication, if you have functional indications as well. Ideal candidate therefore should always be motivated and should be bothered about his facial characteristics and wanting a change definitely. Suited age group is 30 to 75, both for the patient's comfort as well as for the surgeon. So for the upper eyelid, you need to evaluate how much the skin is lax, whether it's associated with any brow drooping or a ptosis that is associated, and any lacrimal gland prolapse which could otherwise be seen in patients with senile or aponeurotic ptosis, as well as in cases with blepharochalasis. So with all non-surgical rejuvenations available in these in the armamentarium, surgical indications for rejuvenation becomes limited. But yes, there are a few set of patients whom only surgery would help, and an added non-surgical rejuvenation is always may be required. But then all such patients have to undergo surgery. So the first one being a very old patient who has a significant upper eyelid hooding, with who might require who might require multiple additional sittings for fillers if at all done, and therefore the cost consideration comes into issues. And the blepharoplasty would not only improve her aesthetic appearance but also help her visually. So for all such patients, the skin marking is done in the sitting posture. The upper eyelid crease is marked, and using a skin marking pen, and the skin is pinched out for the upper lid, making sure that we do not have any leg of thalamus, which could otherwise be causing troubles in the post-op periods. Once you have marked the skin incision very well, you should always cross-check again with the pinch technique that there is no leg of thalamus there. So this was that old patient wherein we had marked the eyelid crease as we do normally in all cases, and using the forceps, we have pinched out the skin and checked for leg of thalamus and marked the upper eyelid skin area. A lateral extension can always be done so that prevents any dog ear formation and helps you take off the skin very well. Using a monopolar cautery, the skin incision should be made, and then the skin should be excised in layers along with an orbicularis muscle. In young patients, we generally tend to avoid the orbicularis muscle. Achievement of hemostasis is very important using a bipolar cautery, because this might result in longer downtime post-surgery. In all such patients, upper lid excision for fat excision is not very well required, but yes, you can always fulgurate and sculpt the fat there with an intact septum using a bipolar cautery. Towards the end, you can close the skin in an interrupted fashion. So this was a patient at 1 week follow-up, and then at 3 months follow-up. So the next indication where you definitely require surgical intervention is the patients with blepharochalasis who come with recurrent inflammatory conditions, and there's a lot of loose hanging skin there. So this was a patient at 1 week follow-up with the sutures in place. Another patient who had lateral differential blepharoplasty done. Another patient wherein you can have blepharochalasis along with an associated lacrimal gland prolapse. In all such patients, it's very difficult to camouflage with the fillers, and it becomes more prominent in certain cases. So blepharoplasty is the only answer for them. So this was a patient immediately on table wherein the lateral swelling has been taken care of very well. This was a patient in trop. The incisions was placed, and the skin along with some amount of orbicularis was taken care of. Post that, the septum was opened up and the central fat pad was explored, and some amount of the bulky fat pad excision was done by crushing into the artery forceps and then cutting with a monopolar cautery. So this was a lacrimal gland that was prolapsed down using a 6-0 vicryl suture, the capsule was hitched towards back of the arcus marginalis, and you can see that the lacrimal gland collapses back into the orbit. So that's how the case is settled out. So another indication being Asian eyelid blepharoplasty, wherein all such patients have a large brow fat span with no minimal tarsal platform show. So in all such patients, what happens is there is a drooping of the preseptal fat pad over the pretarsal fat pad, and an apparent fusion between the aponeurosis and the septum. So this was a patient at 3 months follow-up with an adequate brow fat pad to the tarsal platform show ratio. In all such patients, they also have middle epicanthal folds, which may or may not be touched according to patient's concern in the same setting. So in Caucasians, what we have is the fibrous bands across the coming from the LPS to the skin, which causes the skin crease to form. However, in Asian population, we lack that, and so whenever the eyelid opens, the skin along with the tarsal plate goes up and forms a skin crease. However, in Asian population, that doesn't happen. So we can artificially create it in the Asian blepharoplasty by doing the Asian blepharoplasty using sutures. So after marking the skin crease, since the skin is taken care of, and you remove the orbicularis, wherein the fat is exposed, the fat is retracted back, and then you tie the levatus to the skin there just above the tarsus. Towards the end, some amount of fat can be excised, and then the skin can be closed in an interrupted fashion. So another indication we definitely require a surgical intervention is a differential tarsal platform show. In the right eye, the patient had no tarsal platform show, and that was created in the post-op period. Another indications being prominent eyelid fat pads, especially in TED patients who do not want orbital decompressions to be done, or in a saline patient on the left-hand side who had large fat bags. So this was one indication where we need to excise some amount of fat in the upper lid. Another indication being aponeurotic ptosis, senile ptosis with dermatoclasis. In all such patients, again, we do the normal slit crease marking, and post that, a lateral extension is always made in all such patients to provide more of a feminine design to the eyelid. The excess amount of skin is removed, and the septum is opened up, the tarsus and the LPS is identified, and the suturing, the reinsertion is done. And towards the end, you need to take bites from the deeper bites from the LPS so that adequate skin crease is formed. Another indication where you can counsel patients with a conjunctival fat prolapse to undergo blepharoplasties. So the adjuncts for upper lid blepharoplasty include a lateral orbicularis excision where you can provide some brow lifts in female patients especially, and an endoderm brewpexy. So this was a gentleman who had a left-sided brow droop, who underwent a bilateral upper lid blepharoplasty, and there was endoderm brewpexy done for him. So he was not very concerned about the lower lid eyelid bags. So that improved his visual fields very well. So for endoderm brewpexies, after making incisions as we do in all blepharoplasty patients and opening up the septum, we dissect superiorly, go all along the preseptal plane to reach the periorbitum. At the periorbitum, using a Demar's retractor, we dissect further in the pre-periosteal plane for about 12 mm. Using a calipers forceps, around 12 to 15 mm above the superior orbital rim we mark, and then we pass 60 Weichel sutures from that area to the undersurface of the skin, the deeper tissues of the brow. This adhesion causes the upper sulcus, the upper skin incision, to reach the level of the superior orbital rim and provide some support to the brow fat pads, and thereby help us raising the eyebrow. Coming to lower eyelid, so what again important is for lower eyelid is evaluation of the skin laxity and wrinkling that is present, how much about orbital fat prolapse is present, especially in assessment of the same in the up gaze, and always looking for the lower eyelid tone, because any laxity there might be troublesome later on. So Barton had classified this tear troughs into 4 grades: grade 1, grade 2, which have minimum to mild tear troughs, which can definitely be very well dealt with non-surgical rejuvenation, including fat grafts or dermal fillers. However, for type 3 and type 4, you definitely would require some amount of surgical interventions. So surgical intervention could be in the form of repositioning or excision. So that's a surgeon's choice. That depends on, especially in type 4 patients, you definitely require some amount of excision as well. However, repositioning is what is more preferred. So this is a small animated video wherein after identifying the fat pads, the periosteum opening up is done, and the fat pads are then sandwiched inside the periosteum and brought out using a 6-0 double-ended Prolene sutures. So this was a patient. Fat re-dripping can be done in both the pre-periosteal plane or in the sub-periosteal plane. I prefer in the pre-periosteal plane. So this was one of the patients where we had done a fat re-draping. So fat re-draping definitely helps us in effacement of the lid cheek junction, as well as turning out the negative vector that is always present into a positive vector, smoothing out the tear trough there always. So this was the patient immediately on table. You can see that the patient had undergone right-sided bleph at one sitting and the left-sided bleph in other sitting, both upper and lower lid. You can very well see that the effacement of the cheek junction has happened and the tear trough is altogether gone because of the fat re-draping. This was a patient at post 1 week follow-up of the left eye. So another way of doing fat thing is excision of the fat. So this was this patient where we had done fat excision of all the lower 3 fat bags. So this was a patient at 3 months follow-up where we see that the problem with excision is development of the inferior hollowing of the So why I generally prefer doing is a combination of both, taking out some amount of fat and then redraping the other. This was a patient that you can see that there is effacement of the lid cheek junction and fullness of this hollowness here. A few hygienic procedures that can always be done in when you're dealing with the lower lid. You can do a transconjunctival blepharoplasty and then do some amount of skin tightening, especially in when you have a laxity of the lower lid, or you are combining with other procedures like an LTSS or a providing some vertical support to the patient. So this was this young lady who wanted the wrinkles to be taken care of along with the fat bags. So she had underwent quad bleph, and this was the patient immediately on table post-op, and then at 1 month follow-up. So this is a small video showing a transconjunctival blepharoplasty. I'll just rush through it. So after giving an incision at the conjunctiva and going opening up the septum, you stay in the pre-septal plane to open up the fat pads. You carefully dissect out the fat pads, keep opening the capsule very well, and then identification of the central and middle fat pad becomes very important, and you also identify the inferior oblique muscle well placed there. So any injury to the inferior oblique muscle should be avoided. I do a combination of both, so I have excised some amount of fat pads, crushing them inside the artery forceps, and then cauterizing them very well towards the end so that no retrobulbar hematoma happens. Post that, using a lens spatula, what you do is you take care of the orbital malar ligament, and that is very essential so that you can transpose the fat pads, the central and middle fat pads, post the tear trough area. This can be done using a 6-0 Prolene suture, involving both the fat pads and passing it using a double-ended Prolene sutures towards the tear trough area. So some patients might also require some adjuvant therapies in the form of microfat grafting while you're doing a blepharoplasty to fill up the hollowness that is present in the pupil area. So this is a patient at 1 month follow-up. You should always have anesthesia considerations when the patient's safety becomes of utmost important. Local versus general totally depends on the patient's comfort as well as the surgical setup. In pre-op area, you should always assess for any anticoagulants that the patient is on. Stop it timely. Stop any herbal supplements, including ginseng and green tea. You should always assess the generalized skin conditions and counsel the patients accordingly so that they might have to undergo some non-surgical rejuvenation, including laser skin resurfacing. So the pre-op counseling becomes very important, setting the realistic outcomes. At times, patients are very demanding, so they should be knowing what can be achieved and what not, and that they might require long-term maintenance for whatever outcomes they have at present. You should always also tell them about the downtime. This is the patient at multiple stages of follow-up at 1 week, at 3 weeks, and then at 6 weeks to 8 weeks. You should always tell them that it would take around 6 to 8 weeks to be very socially acceptable later on. In post-op care, managing the pain and swelling is very important. Give adequate ice applications and head-end elevation should be done. Some dose of steroids for a week's time can always be provided. Management of complications again becomes very important, especially the ectropion and lid retraction that generally happens in the hand of general plastic surgeons. So wherever you find that there is laxity of the lower lid, a lateral skin tightening always helps you out. So to each their own, it's always a patient's and overall a doctor's comfort to what the patient would require, and then meanwhile balancing the safety and aesthetics. Thank you.
Thank you, Dr. Sahil. You actually covered each and everything that we do commonly. And do you personally prefer doing your fat repositioning subperiosteally or preperiostally?
So I prefer doing it pre-periostally, and I also do a combination of both. I do an excision, some amount of fat excision, especially in type 4 troughs, along with draping of the fat pad.
I do it pre-periosteal.
So we have the last talk for the day. Dr. Aditi's talk, can it be please played? She has been kind enough to give us a pre-recorded talk on cosmeceutical magic banishing the periocular wrinkles and dark circles. I'm so sorry. We'll also have Dr. Prerna's talk after this.
I think next session is we are
This
already
is the last talk that we have.
My topic for today is cosmeceutical magic, banishing
because
for
छः
making
बज
me
गए
a,
ना already
thank you for
already
making
6
me a
o'clock.
part of this
हाँ it's
brand
5:55.
presentation instruction course. My topic for today is cosmeceutical magic,
Can you please raise the
banishing
volume?
periocular wrinkles and
दिख
dark
ही नहीं रहा है.
circles. There are no financial disclosures for this presentation. So when we are looking at repairing a building which has weathered the time
7 मिनट
of
का ये
storm, weather,
गाड़ी का
age,
बिल्डिंग को दिखा रहा है.
we look to restore its structural integrity, which includes basic framework.
नहीं सैन
We do
फ्रांसिस्को
minor repairs, but
तो आया 11 मिनट का टॉक है ऐसा.
That is what makes a lasting impression. That is something which really contributes to making it look rejuvenated, refreshed, new. And this is what today's talk will be about, restoring this facade and maintaining it with some over the counter medications known as cosmeceuticals.
फील भी नहीं है
So,
ये
if
तो
you go to a
ऑलरेडी ऑटोमेटिक
supermarket and look in the shelf, you'll find a
बट
wide
साइड पे
variety of skincare products which are easily available without prescription.
व्हाट अबाउट हियर.
The major category of these includes the sunscreen. Then you have some peptides, which are supposed to be the actives or the bioactive compounds which bring about a change in the skin texture, color, tone, address common skin concerns. And other ingredients like multivitamins, ferulic acid, retinoids, and peels, which help in restoring this facade of the skin and making it appear youthful and supple. In short, all these products are available in a jar on the shelf in the supermarket. So the term exactly what does it mean? It was introduced by Albert Kligman in 1984. So cosmeceutical actually means products which are known to exert a biological action but regulated as cosmetics. So when these cosmetics come into the regulation for these is not as rigid as the pharmaceutical products. They are articles intended to be rubbed, poured, sprinkled, or sprayed upon. That means they remain outside, they're not invasive, they remain on the surface of the skin, and they can be applied to the human body for cleansing, beautifying, promoting attractiveness, or altering the appearance. Compared to this, a pharmaceutical drug is a substance which is intended to affect the structure and function of the body. Here, another term comes in, which is the nutraceutical, which is like a cosmeceutical but is introduced inside the body, that is, it's ingested. So, most of these products are contain generally recognized as safe ingredients. There's an ingredient review board which lists the chemicals that can constitute a cosmeceutical and can be marketed in the supermarket rather than the pharmacy without requiring rigorous trials before it's launched into the market. Because of this reason that the trials are not really done for them, there's a tendency to dismiss these as ineffective as the regulation is limited, but actually they may have a lot of potential benefits, but they're just not studied. So we have to rely a lot on clinical data as well as the data provided by the manufacturers as to how much efficacious they can be, and also delve into them, see your own experience. So, what all concerns can these cosmeceuticals address? They can address periocular pigmentation, they can address the fine lines and wrinkles, which are quite bothersome and may present to your OPD as the patient is seeking periocular rejuvenation. Coming to the categories individually, the most important of these for the periocular region, along with the sunscreen, I always recommend sunglasses. The next would be the retinoids, out of which the least potent retinol is available in a lot of these creams, anti wrinkle creams over the counter, and this is considered as a cosmeceutical. Then you have the neuromuscular relaxants and peptides, which include your arginine, Vialox, Leuficil, DABA molecules. And if you look at the shelf or if you look on Google, almost all anti-wrinkle creams contain one of these compounds designed to act like a Botox and reduce the neuromuscular contraction and reduce the fine lines and wrinkles non-invasively by applying them topically. Some results are noted with these products as long as the patient continues to use them regularly. The next is products specifically targeting hyperpigmentation, which can be either via masking or by reducing the melanin appearance or the production, that's by the tyrosine kinase pathway. And the main products in this include the hydroquinone and azelaic acid, which are prescription based, and the cosmeceuticals like arbutin, licorice, vitamin C, and kojic acid. Keratolytics, which are the alpha and the polyhydroxyl acids, which basically increase the skin turnover time by removing the epidermis and allowing the dermis to shine through. The new layer of the skin, which comes after the application of these, is supposed to be uniform and appear more glowing, and the texture seems smoother. The other advantage of keratolytics is it improves the absorption of the other product categories by removing the top layer of the skin. Then we have the antioxidants, vitamin C, E, resveratrol, which is available in topical formulations. Then we have some growth factors, which can be plant or human based. And then we have barrier function, that's repair creams like your moisturizer, ceramides, urea, and hyaluronic acid. Combinations are supposedly more effective when used wisely. Also, there's a significant ease of use because there are lesser number of creams to apply. However, if a patient is allergic to one of them, then we need to stop the entire combination because we cannot really pinpoint which product the patient developed allergy to. A common example which I like is for the periocular pigmentation, a vitamin C with an E cream, which has a double action when combined. And if you add to it the ferulic acid, it leads to an increased absorption in the periocular region with dramatic improvement in the appearance of dark circles. The last topic that I'll be touching will be the eyelash and eyebrow growth serums, because many patients do come in asking whether these are safe for the eyes. Doctor, I've heard they're made from an eye drop. So we do have prostaglandin based analogs which are in these serums like the bimatoprost, latanoprost, but we also have PG free products which contain castor oil, and they do lead to some improvement in the appearance of the thin hair by making them thicker, increasing the density, increasing the growth. But yes, be cautious when you're using them. For example, we are all aware about the prostaglandin analog and the lipodystrophy around the eye. So we should be cautious when we're using them, and always counsel the patients regarding possible side effects and when to report back. With this, I'd like to end my talk. Thank you very much for your patient listening.
I thank everyone to be who. So, can we hand over to the next team of TOTs, teachers for tomorrow?